All these transhumanistic groups aren't calling me. I'm saying, Ron, because you haven't created a collaboration amongst your 30,000 doctors. They're all out there wildcarding it, doing their own thing, great things and creating great data, but traditional medicine has what they call evidence-based medicine. We know there's a lot of bias in that medicine, but they point to non-traditional doctors as having quackery or anecdotal at best without having evidence. So one of the things I'm going to talk to you about today is how we can, as a community, actually start collecting really good population data to disprove that we're lacking evidence. So let me just tell you the story. Cleveland Clinic, Mark Hyman, functional medicine, published a paper 3 weeks ago showing that their approach outperforms allopathic medicine. But let me tell you what the problem with that paper. 27 years, 30,000 doctors, one paper. What's wrong with that? Not enough. Because we're all working independently, in silos, on our own. And what I'm going to present to you today, a little self-serving, but it's how you, because as biological dentists, you have people much more motivated than most coming into your practice. Are you asking the right questions to find out what a gap analysis, what they're lacking? Because I can tell you they're lacking a lot. I do a lot of surveying. And then I'll tell you how we can potentially work together and as a community to start building bona fide data sets about important attributes of health and showing connections across what I call multidimensional layers of health, from lifestyle risk to actual disease and everything in between. So I hope some of you might consider joining me. So what I'm saying is our customers, the customers coming in for dental care are looking for advanced dental care, but they're being neglected across many, many other segments of their health. And now how I'm going to tie in my original talk to subject to dental today is I run a direct-to-consumer coaching, high-level diagnostic, disease prevention, reversal, medication, withdrawal program, all that good stuff. But I also work with corporations, and I come in and my shtick is I work with the sickest of your community, because 5% of any population drives 60% of costs, and no one's addressing that. So I said, like the Statue of Liberty, give me you're sick, you're tired, you're poor. Those are the people I want to work with. So 2 weeks ago, I had a lady join my program through the corporation. Corporation pays for the whole thing. 44 years old, severe glaucoma. Ran a survey. I asked a lot of oral health questions, and she said, well, I haven't been to a dentist a long time. My gums don't bleed, don't floss. I said, ma'am, you need to go to a dentist. Let's be real. Because I know these associations. She goes to the dentist and reports back to me, and the dentist says that she needs to have every single one of her teeth removed, every single one. So what do you think's causing the glaucoma? So, we're working on trying to create bridges between these disciplines, and what I'm hoping to do today is just make you more aware of how the eye can actually be a barometer for health, but that's what I call dimension 3. I'll get into my dimensions in a moment. Let's see if I can get this clicking. Quick facts. I think dentists possess unmatched screening and diagnostic capabilities. I mean, optometrists are pretty good too. They see things, and I'll show you about that, but you're seeing the disease that's right there. You can measure it accurately. It's, a cardiologist doesn't have the diagnostic prowess you have. Chronic disease drives up 90% of healthcare costs, and we have the worst chronic care management system in the world, so it's a huge opportunity. Up to 30% walking into your practice don't have a primary care doctor, and a much higher percentage don't trust that doctor or don't want to go really to see that doctor. I work with people that are grinding railroad ties to make energy, okay? And they don't even have high school educations, and they say, look, I don't go to my doctor because all they do is look at their computer screen and write a script. So it's like these are people with low health literacy and low literacy in general, but they get it, okay? They're coming into your office, and you've got at least 150 million dental visits. Let's find out what our customers need when they're coming in the door every day. And there's a simple jot form I use. It's a simple 10-question questionnaire to find out who they are and what they need. It's very simple. You can run that online, you know, and while they're in the office, and they're, you know, it's done in a jiffy, and then it's all digitized data. You can get a report. If you can read a report card, it takes you 10 seconds. But here's the problem. This is CDC. 90% of the nation's 3.3 trillion is tied to chronic disease. Now, one issue we have is motivating people. I'll talk about that in a minute. But it's a big issue. It's an unmet need, and it's as big an industry as, you know, it's 6 times bigger than the automotive industry in America. 6 times bigger, that healthcare budget. So the Organization of Economic Cooperation and Development studies 36 nations, developed nations around the world, and one of the attributes they look at is healthcare. And so this little chart is put together, and we really have an American paradox because we spend 2.5 times more. Do I have a... Yes, we spend 2.5 times more than the average OECD nation, and we live 2.5 years less. So it's an obvious formula. We can spend more on healthcare and live shorter. So the more we spend, the shorter we live. And you might ask why this is true. Well, in Europe, primary care docs, they don't do fantastic things in chronic disease management either, but the primary care doctor is paid more, and they tend to do much more care, whereas here it's just a turnstile to send you to a specialist for procedures and medications. And that's the biggest driver of this cost factor. And, you know, we need to solve that. It's a huge, once again, it's just a huge opportunity for us. So I'm not going to go over objectives because the objectives changed, and let's see if we can get it through. But I would like you to understand the ocular whole body health connection by the time we're done. But, you know, what's our incentives? This was a very interesting study because genomics became a very big thing. And, you know, everybody wants to do the 23andMe and do epigenetics. Well, my mentor at Harvard, Dr. Tremp, was doing allele testing in the 1990s. And when he found someone had a very adverse allele versus a good allele, but they came in with sort of the same indication, when he treated the patient right, they both got better. So we stopped doing genomic testing, but this group here, National Geographic, 2013, spent 6 years going around the world looking at centenarians to figure out what was making them healthy. Okay? And really, the most interesting thing from this is we presume if we live a long time, we're going to live decrepit. But in fact, if you live to 105, you have 9 years of declining health. And everything in nature is a bell curve, you know, an asymptote, not linear. So you really fall off the cliff very rapidly. Whereas when you die at 80, you have 19 years of declining health. I mean, do you think someone at the age of 60 who's going to live to 105 is decrepit? Okay, versus someone who's going to live to 70, they're probably pretty decrepit, right? So there's every incentive. So what you get by living longer is you get another, you know, 120 to 150% health span increase by living longer. So, you know, mortality is clearly tied to morbidity. And the earlier your mortality, you know, some people die very quickly, but for the most part, it's really advantageous to be healthy and live longer. And I loved the previous talk was fantastic about the basics of it. I follow the New York Times well blog, even though Jan says don't follow the New York Times for political reasons. I agree with her there. But, you know, their well blog does some very interesting things. And I'd say, I'm going to use my Boston accent even though I live in East Tennessee. Half the times they're right and half the times they're wrong, okay? But when they're right, they're really right. And this is interesting because they say, you know, for the elderly, diseases overlap. You know, duh. In my world, there are 3 mechanisms for chronic disease. And from that perspective, kind of like all disease. Inflammation, you know, gut permeability, sensitivity, sensitizations, and then cryptic and chronic infections. And for the dental group, there's no group that understands chronic infection in terms of affecting systems better than you do. And I can explain almost every condition based on those 3 mechanisms, and they overlap too. And of course, you know, if you get rid of the organ-based disease syndrome and look at things from a fundamental physiological perspective, then it's obvious. Go to the American Cancer Society, American Diabetes Association, all the associations, look at the risk factors. Even though they siloed the disease for the drugs, all the risk factors are the same. So here we go. And all I'm saying is, you know, we're not measuring. If all we're measuring is A1C and lipid, you know, we think the elephant's a rope. You know, we've got to expand the depth and breadth of the testing that we do. One quick anecdotal story. I had a lady in Oregon join my program, direct to consumer, and my first phone consult with her, she was very confused. And she'd been a neurologist. They kind of thought she had dementia. They were going to put her on Aricept. I did a blood test on her. Fasting insulin. Why would anybody do fasting insulin? I mean, diabetes is just insulin resistance, so let's measure something other than insulin. It's a crazy, crazy world out there. Everybody should be measuring fasting insulin. Her fasting insulin was 1.15. And then I did it again with C-peptide, and it was reproduced. So this lady at the age of 80 is becoming a type 1 diabetic. So the reason why she has brain fog is, you know, the brain is the second most metabolically active tissue in your body, so it can be very vulnerable to inflammatory vascular conditions. The most vascular and the most metabolically active is your retina. And that's why we're going to talk about the eye a little bit. So she was really just having her brain was suffering from an energy crisis, from the fact that her pancreas is dying. And by the way, since I'm dealing with a group that understands infection, she had a couple different spirochetal infections in her peripheral blood, which we're now working on treating. So let's not use the laser. Let's actually go forward here. And I forgot to fix that. So one of the challenges is when I go into a corporation and pitch my program, they say, well, you're not going to reach the sick and needy because they don't want any part of you. You know, wellness programs fail because the 70% that are healthy join the program to get free membership, a little discount on their insurance cards, but it's hard to get it. But what we do is we talk about touch points, you know, the sleeplessness, the chronic fatigue, the chronic pain, those kinds of issues that tend to be more organically important. You know, wellness programs are often called, you know, a fat humiliation program. So they don't work, but what we're doing is we're now accurately measuring across 4 dimensions, you know, what I call determinants of health, physiological, pathological, and then disease states. Now, the problem we do have is that everybody is looking for that one pill. We've been programmed for instantaneous gratification. Take this pill, solve your problem. But even my, you know, low health literacy cohort realizes that that pill is not solving their problem. So we're starting to go through a transition. I mean, look, when Walmart is selling cauliflower-crusted pizza, the world's changing. And we have to be amenable to that change and meet the needs of the people out there that are looking to affect that change by bringing bona fide solutions. So, you know, Scientific American published this in 2002, a separate 88-page publication. It's hard to find it, but if you don't have it, drop me a card and I'll send you a copy. I'll put it up on Dropbox for you. And I went and saw Jeremy Abbott in New York City with my team 6 years later and said, let's do ocular and whole body health. And he said, well, I'm not quite ready for that, but he's getting to the point now. I just was talking to him very recently about doing the same thing in the ocular realm. But here's what I'm doing with forward-thinking optometrists. They are now going to be doing, I got a pilot with a half dozen or so, they're going to be doing functional ocular assessments, looking at eye pathologies, which I'm going to show you, that relate and highly correlate to cardiovascular disease, neurodegenerative disease, and autoimmune diseases. So they're going to do a functional consult with a slight upcharge, and I think dentists can do the same thing. It's have the consult with the correlation between the oral cavity and systemic disease and start really promoting that more. I know a lot of you folks are already doing that, but what I want to do to add to that is get my clicker to work. Come on, you can do it. There we go. So here's the 4-dimensional health program. In the allopathic world, you're either healthy or you're sick. My wife's a Puerto Rican from the Bronx, and she was also born under the Leo sign. So I have a T-shirt which she gave me. She says, pray for me. I'm married to a Puerto Rican, okay? But so she goes into with her mother to her primary care doctor, and the primary care doctor, looked at her labs, A1C 6.4, and says, all your labs are fine. Of course, at 6.5, you're a type 2 diabetic. Now she can prescribe metformin or whatever else, but at 6.4, you're perfectly healthy. Well, really, you want to be between 4.5 and 5 to be ideal, but, so it's a wackadoodle system. Tom, is that a word you ever used? I don't know if you've ever used that one. But, Dimension 1 is just looking at risk factors, determinants of health. And what we've done is we've created a digitized online form, but the cleverness to it is we've assigned a risk score to every question-answer couplet. So now I can sort by, root canals, night sweats, bleeding gums, fast food, and you very quickly get a stratification across this domain of who's your highest risk and lowest risk. Blood labs, I call it physiological perturbations. I spent 2.5 years of my life with a biostatistician combing PubMed to see when a marker like C-reactive protein or even white blood cells, when it gets to a certain level, actually causes a statistical increase in mortality. Isn't that an important marker? When you go in now, reference intervals are based on the statistics of the population that came in and took their labs. What does that have to do with health? They admit that if you're in range, it doesn't mean you're healthy, and if you're out of range, it doesn't mean you're sick. So, I'll give you an example. The Nurses' Health Study, Women's Health Initiative at Harvard, 138,000 women. If I take two groups of women, one with a white blood cell count of 6,700, well within normal range, and one with a white blood cell count of 4,700, once again well within range, and follow them for 6 years, the women at 6,700 had 50% higher mortality. Okay, and that's a relative statistic, but to the 50%, that's important. So we've created a whole new scale. It's not a diagnosis, but it's based on abnormal values being linked to early mortality. So the ranges are much tighter than the reference intervals provide on LabCorp and Quest, but they're much more predictive of future health risks. So for example, if you have periodontal disease, low-grade infection creating inflammation in your body, C-reactive protein goes up a little bit, white blood cell goes up, but you're still going to be way within the reference intervals, even with severe periodontal disease. So the labs aren't diagnosing and aren't giving the kind of factual, objective information to your patients because they say, hey, I'm within the reference interval. I'm normal. You're not normal. You're at 6,700. That's high risk. You should be between 4,000 and 5,800, preferably 4,500 plus or minus just a few hundred to be optimally healthy. Oops. So go back here. Dimension 3, one thing I'm going to talk about is we can measure tissue changes. In that example I gave you at the beginning, cataract, glaucoma, macular disease are really barometers for inflammation and infection. So if your patient comes in with periodontal disease and they say, what the heck? Well, one of the things that might manifest in the near to distant future is you're going to go blind because you have eye changes. But if you're not aware of that and not asking those questions, cataract surgery is the #1 surgery in the world, and I'll get to that very quickly. And then Dimension 4 is just measuring comorbidities. Yes, you have chronic fatigue or you have dementia, but what comorbidities go with it? And if we look at like a dementia or an Alzheimer's in isolation, we'll never see the correlation between early depression, insulin resistance, diabetes, and all these things. They're out there in the literature, but no one's really publishing well on these correlations. So here we go. So how many did I go ahead? So you can say in this report that the guy up in front doesn't know how to run a clicker. It's true. I have my son do the clicking for me normally. But just some basic relationships, easy to find on PubMed. Potential relationship between periodontal diseases and eye diseases. What I didn't put up here is, the eye is actually a canary for inflammation. If you have inflammation, swelling, and dysbiosis, in the eye, you could potentially, get blurry vision. You're not focusing well. Well, from a survival perspective, that's not good. So there's a concept called ocular immune privilege, where your eye actually denies inflammation and actually can become more vulnerable for it. So it's actually a canary for inflammation. The eye-tooth connection. Patients with more dental work are also more likely to have glaucoma. I've proven that. Unexpected relationship. When you realize there are only 3 mechanisms for chronic disease, and this is a major driver of infection and inflammation, then it's pretty clear. Glaucoma, macular disease, macular degeneration, wet AMD, where you actually have bleeding in the back of the eye, that's a vulnerable plaque that is now erupted. God help you if it's happening in your heart, but it's your same vascular system. We may not like Lance Armstrong, but I use him as an example. When he's climbing Alpe d'Huez and the Tour de France, the same red blood cell is passing through his heart every 10 seconds. Every 10 seconds, okay? So we can't think in capsules. The brain uses 25% of the oxygenated blood that leaves the heart, and it's only 2.5% the mass of the body. So it's 10 times more metabolic than average tissue. So when you talk to a neurologist and they start talking neurons, say, no, Mr. or Mrs. or Dr. Neurologist, tell me about my vascular health and how that relates to my brain. And then, you're going to hear cuckoo going on in the room, but that's just my view on certain neurologists, not the one we had up here earlier talking about sleep. She's fantastic. But it's no coincidence that many vision starts to go wrong around the same time you're having oral problems. Association between tooth loss and Alzheimer's disease. Did I skip one? There are more microbes than we detect in the mouth. And so what we do is we do a very robust panel on vector infection. Everybody familiar with rickettsial diseases, Rocky Mountain spotted fever? I mean, half the people, maybe 80% of the people, if they're my age or older, have so-called historic chlamydia pneumoniae. It's really the dormant phase. I think it's kind of interesting. You talked about dormant bacteria. It's interesting that the medical community says that, shingles, herpes zoster, is in the dormant phase, and we're kind of brainwashed to think that it's the only type of infectious species that can lie dormant in our body and come back to play when it sees an opportunistic moment in your body when you're compromised. And I'd say the number one infection, certainly tied to Alzheimer's, is chlamydia pneumoniae, which is transmittable through the air. It can reside in the gums. It's a respiratory pathogen, but its favorite thing is the tissue of the blood vessels, endothelial dysfunction. We had a lot of talk about the gut microbiome. The top guy in the world on this was on the Nobel Prize winning team, discovering that H. pylori forms stomach ulcers. They won the 2 Australians, but Thomas Barodi, I consider the top gastroenterologist in the world, developed the triple antibiotic when Marshall infected himself to prove that H. pylori caused stomach ulcers because no one would believe him. Today, Thomas Barodi is working on fecal implants, better than probiotics because you're getting old friend microbiota being reimplanted in your body. But I have an interview from him that he said he found he had chlamydia pneumonia, and he treated himself for 3 years. And he said he did that for one simple reason. My heart's important to me. Okay, so just a little sidebar on that. So microbes, my good friend Judith McCloskey in Switzerland has published in 1993, and she's been proving it to be correct to crickets, that her first paper was titled Alzheimer's Disease, a Spiroketosis, okay, with a question mark after it. But she's since proven it every which way but Sunday. So, mercury's bad, but indentuism is worse. If you have bacteria in your mouth bad enough to lose teeth, that bacteria is spreading. Someone talked earlier about premature death rates of infants. We're tied with Vietnam and Somalia for the highest premature birth rates. And the University of Arizona did a study that showed that periodontal bacteria in the placenta is probably a cause of at least 50% of the early aborting of or attempted abort of life, because, you know, it's an infected milieu, and that fetus is probably not going to be thriving as well. Okay, very obvious reasons. So the public has spoken that what you're doing is extremely important. So here's a company in San Francisco that's developing a drug to treat periodontal disease in the brain as a treatment for Alzheimer's. And I believe it's going to work. I've studied thousands of trials that have all failed. This one I bet you is going to work. And why I say the public has spoken is because they're on NASDAQ, and right now their market cap is around $800 million. So the public is saying this is important, and this is most likely valid, and it makes a lot of sense. So I'm going to get a little deeper into the eye right now. This is a child in sub-Saharan Africa. This is New York Times. And you can see a very pronounced nuclear cataract. So this is, and the doctors said they were surprised or shocked to find someone as young as 5 with a nuclear cataract. Well, it's an unfolded protein response. Harvard has shown that when you have misfolded or unfolded proteins, they're actually part of the innate immune system's response, and they fall into a class of peptides called antimicrobial. So this young girl is expressing a profound immune response against Ebola infection that's most likely in her eyes. Obviously systemic, but resident in her eyes as well. So cataract is actually a sign for acute infection. Here's another thing on Alzheimer's, just showing you that we see plaques visible in the eye, no cutting, no fancy instrumentation, non-invasive, very precise, and it shows up 15 years prior to the development of cognitive dysfunction. So you can see these plaques. The plaque is not the disease. And the drug companies, Pfizer pulled out after spending like 20 to $50 billion on anti-unfolded protein treatments that have failed miserably because they're trying to treat something that's part of your innate immune response. Obviously, it's not going to work. And friends of mine in 2004 published that, you know, this is just the wrong mechanism, but here we are in 2020, and 2019, I still see articles on, you know, new companies forming to get rid of these plaques. You don't get rid of these plaques, you get rid of the problem that's underlying the plaques. So all this is saying is, you know, the reason why the eye is particularly interesting is, number one, it's the most vascular tissue in the body, and number two, to transpose the signal, you have to go across many synaptic connections to the back of the brain. So it really is telling a story of what's going on in your entire brain. So it's really quite interesting. So here's an interesting book. It's I don't recommend anybody read it unless you're really a biochemist or a physiologist, but it's very intense. But, you know, John Dowling is a chaired professor at Harvard, and he wrote, you know, the retina, the approachable part of the brain, and how the retina is actually a great, great place to analyze neuronal functions actually happening in your brain. So I'm just going to show you some slides. This is a 2003 publication from Harvard. I have to give Tanzio, this is not the Tanzio, this is 86, how, you know, we can actually measure stem cell health. The lens is the most unique tissue in the body. You know, it kind of disavows you have to have one capillary within 3 cell diameters of every living cell, except for the fact that the lens is one gigantic cell. In fact, it's one gigantic stem cell. So what's going on in the lens of the eye very much tells what's going on in the rest of your body in terms of the health of stem cells and regeneration. This is the Harvard study from 2003, and what they showed is this particular type of cataract. This is a nuclear cataract, and it's the one that optometrists and ophthalmologists pay attention to. It blocks central vision, and they yank it, and they give you a new lens. But this is highly tied to cardiovascular disease. I'll talk about that. But most eye doctors of all ilk ignore these cataracts on the periphery because they don't affect vision. And that's called a cortical cataract. But what Harvard showed is, let's see if I have that one up here. But what they basically showed is that this is the cortical fibril cataract in a living human being. This is a slice of an autopsied individual. But Harvard looked at a bunch of Alzheimer's people who passed away, autopsied, and showed that this protein was present in the eye in essentially all that had this in the brain. And then they did all their fancy techniques and showed that it was the 1,4,2 beta amyloid, chemically exactly the same protein. And not much talk about it, but Harvard patented the entire eye, and they formed a company to measure this, but they really haven't got the science down well enough to sort of quantify it. But any good eye doctor can measure you today for a supranuclear cataract or cortical cataract. And we're probably the only group in the world that's interpreting eye data in terms of your pathological health and your future likelihood of migrating into a condition like Alzheimer's. So here is sort of the pathway. Just like anything, you don't catch Alzheimer's, you don't catch heart disease, you don't catch diabetes, you don't catch a cortical cataract. It develops from what's called comaberration, early swelling of the lens, to this sort of Milky Way, to a fibril, to spokes, then to a full-blown cortical cataract. These people already pretty much 100% have dementia, whereas these may not. They're just starting to maybe suffer from cognitive impairment to some extent. Sleep, great talk. Where's my gal that did the great talk on sleep? But a lot of the dysfunction in the brain, we had migraines, things like that. These are energy crises. A migraine or a headache's an energy crisis in the neurons. Okay, and we've shown that, I had one major case, but tons of smaller cases. This lady was taking 4 meds for migraines since she was 18 and she was 41. And, beta blockers and all kinds of things. And we measured her, and she had Toxoplasma gondii, Lyme disease, or rickettsial disease, and we treated her with pretty heavy antibiotics for 3 months. And for the first time in her life, she was off all drugs and migraine-free. So, sometimes, I agree with everything everybody's saying, but we go through we're on this continuum, but when you go over that slippery slope and infection takes over, it's not like heavy metal toxicity. Those infections now, it's the bacteria in a petri dish kind of experiment where they're growing extremely rapidly and they're getting out of control, and you got to treat them. So what the eye shows is neurodegeneration way before you can detect it in the brain. And most people go for an MRI scan way too late. When you have mild cognitive impairment, Mass General showed that you already have 17% atrophy. An MRI is expensive. We can't screen the population early, we'd go broke. But an OCT, which is more accurate than MRI, it's a tomography of the back of the eye. I have eye doctors that'll do it cash for $50, and it's amazing the kind of detail they can get on age-matched assessment of what's going on in the retinal nerve fiber layer, which is a surrogate for the brain. Extremely impactful data. So, you have someone with bad periodontal disease and they're not motivated to make change, send them to an optometrist and get an OCT, and the optometrist can corroborate that, hey, you don't just have periodontal disease, you have a ongoing neurodegenerative process that ain't going to turn out good unless you do something about it. That might be a tipping point for them. We don't know, but obviously inflammation is the key driver. Infection drives inflammation. Gut sensitivities drive inflammation. Another New York Timers, new published study in neurology, inflammation in midlife, brain shrinkage later in life. Look, if your white blood cell counts are up, your C-reactive protein's up, homocysteine, SED rate, things like that, you're fighting something. This is what I tell my participants to do, the junior high school educated people, It's take a pen, paper, something, and just gently rub it on the back of your hand, and then stop. Nothing happened, right? Now I'd say, do this 24/7, and I'll come back in a week. And what do you think is going to be happening? What's going to happen to the skin on the back of your hand? They said it's going to be rubbed raw. So if you have an inflammatory process, poor oral hygiene, high insulin, eating the high gluten, and knowing it's creating a little, discomfort in your system, you're just triggering this low-grade inflammation that's no different than rubbing here. And if your insulin's 10, put a pressure of 10 on. If your insulin's 50, put a pressure of 50 on. And that's just how much more rapidly that's happening. Tom Lockensgaard said earlier, it's all about energy, but also, what did you call it, Tom? Not repair and recovery. I call it repair and recovery, but yeah, autophagy, food is the most important component about food is not the calories. If you're driving down the highway and your alternator light comes on, going to the gas station and filling up with gas ain't going to fix the alternator. You got to repair the whole house. So repair and recovery is way more important than calories. We have something in our body called adipose tissue. You get all the calories you need for quite a while, but you need nutrients. And, your body will steal nutrients from your bones if you're not good enough to bring them into your body, so, you don't want to do that. So nutrient density is the whole thing. Just more eye things. This is a little thing called drusen, early macular disease, but Don Anderson out of UC Santa Barbara spent his entire life, 30 years, showing that the drusen, early macular disease, which eye doctors just observe, and kind of like the doctor with my mother-in-law, waits till it bleeds, then I can do injections. That's too late. But these drusen are also the 142 beta amyloid that we find in the supranuclear cataract and we find in the Alzheimer's plaques of the brain. Same exact thing. So here's the ARID study. In the ARID study, let's see which slide I have here. I'm just going to skip on, but basically, the ARID study, age-related eye disease study, shows that if you have an early cataract, your 6-year mortality is very high, and it's the same as if you've been diagnosed with breast cancer in terms of mortality. Anybody out here been on a cataract walk? Any chance? Anybody? No one? No cataract walks? Anybody? It's not well known, but it's well published, and there are 16 global studies now that show the same factoid. If you're not 100, but if you're 80, 70, 60, 50, and you have an early cataract, your prognosis for cardiovascular mortality is high compared to your buddy, same age, without the cataract. That's simple. So even a nuclear opacity, sudden change in vision, which is usually tied to an early cataract, age-related macular degeneration, cataract surgery, it's not from the surgery, it's the fact that the cataract has progressed so far now that we need to pull it out because it's really blocking your vision. These are the kinds of things we see. So we have a blank slide here, I guess. That's good. So here's the studies, from China to Australia to all over Europe to America. One common underlying thing. When people have cataracts, it's an early warning sign of dying, usually from an underlying stem cell or cardiovascular type disease. I won't spend a lot of time on this, but it's really interesting. The lens is like the rings of a tree. If you know how to look at it carefully enough, you can see sort of a life history of the health of stem cells over time. And I'll skip on that one there, but here's the pathology. Here's a little blood. When someone goes in with mild cognitive impairment and they run an MRI on them, neurologists will generally say the person's had multiple microinfarcts, small hemorrhagic strokes that they didn't even feel. In the eye, you can see it. It's called wet macular degeneration. But really what it is, and this is how we tie it to the mortality curve, years out versus like probability of dying in that certain amount of time, And there's the drusen. That's just the dry AMD. If you go to your eye doctor and they say, oh, no big deal, you just have a little dry AMD, you start worrying about what's causing that and what it might do to your brain 20 years out. So what we're really seeing here is that this wet AMD is actually a vulnerable plaque. And it happens from the inside, from the outside in. One of the fallacies of every medical office is they show a very simple thing. They show the cholesterol building up on the inside and creating blockage. This is completely wrong. And it was proven wrong by a little German pathologist in 1876 who understood that disease happens from the small vessel to the large vessel. So this is how I teach my population. When you're at home and you have some crud and you put it in the sink, what pipe clogs first, the big pipe or the small pipe? Anybody know? The small pipe. You just know more than 99% of the cardiologists in the country. You know, I mean, it's that simple. So the real truth is we have the vasa vasorum, and it's full of microvessels. You have to have a capillary within 3 cell diameters of any living cell, so this area has to be healthy. And when this gets plugged up with inflammation, we can measure that with red blood cell distribution width, calcium deposits, C-reactive protein. Then it can lead to problems in the big vessel. And of course, there are many probably microinfarcts occurring here that you don't know about, but they're portending the big one, if you will. So this is my good friend at Harvard, Macaulay, who discovered homocysteine as a huge risk factor for cardiovascular disease back in the 60s. And what he's showing is the vasa vasorum being contaminated, and we have LDL aggregates, which is really just LDL just delivers healing molecules. They're the fire truck bringing the water to the fire. Never get your LDL lowered if you want to repair and recover well, because it carries, LDL is simply soap carrying important anti-inflammatory fat-based molecules through your bloodstream from the liver to tissue where you need repair and recovery. And this is where it's coming to, and you have all the cytokines building up, but it's all driven by inflammation and infection in the small tissue, the small vessels. So I equate vulnerable plaques and plaque buildup in arteries to, guess what? A zit. That's what it is. It's a bag of cytokines from the immune response. And what causes profound acne? It's an infectious disease. They treat it with minocycline and other things, profound acne. So this is the exact same process that's going on inside your bloodstream in the microvessels. And it could be happening in your heart, it could be happening in your brain, it could be happening anywhere. So if anybody really wants to understand about sort of the mechanism of inflammation and infection in disease, there's no more elegant pathologist, dignified individual than Kilmer McCulley. He's still going to work every day at Harvard VA, chief of pathology at the age of 85. And my mentor, Dr. Tremp, when he saw this paper, I came to his office, it was 2009, I said, what's that, Clem? Because he's just writing away in 4 different colors and 13 pages, and half the text were highlighted. And I said, that's a good one. He said, who's that? He goes, McCulley. I said, who's McCulley? He goes, well, he's the pathologist right here. So I called up McCulley. We had a 6-hour lunch, and we've become famous friends ever since. But just, you know, he's written more hypotheses papers than anybody I know, and he's usually spot on. So a great paper to really learn about disease mechanisms. And is this Judith? But anyway, you know, chlamydia pneumonia, clinical isolate from, so you know, chlamydia pneumoniae is a respiratory pathogen, but we're finding it in the oral milieu as well. And now the question is, what migrates to the rest of the body and attacks the endothelial tissue to cause heart disease, which is still quasi #1 killer, and it could be that pathogen. And it's usually never one thing. They go together. It's like a gang. So let's see. Is this Judith. I'm just trying to see who my papers are, but the role of chlamydia pneumonia and the pathogenesis of periodontal disease. So, you know, it's basically piling it on. So if you're not familiar with chlamydia pneumonia, I think that's an important thing to be aware of. Helicobacter pylori, I believe, doesn't start in the stomach. I think it starts in the gum lining. And Dr. Trump, my mentor at Harvard a long time ago, said, you know, I keep treating people for H. pylori, and it keeps coming back, but I think they're just being reinfected. So I have a group of workers down in North Carolina, and I just brought them on a little while ago, and they're all sharing the same vaping device. And, you know, I tested them, and 80% of them were positive. One had very severe GERD, and I tested them, and 80% had H. pylori. And I don't test for H. pylori in the stool. I think it's too expensive. I do it in the peripheral blood because it lives in the blood vessels, okay? So if you have just simply an IgG positive for H. pylori, that's, you know, you're positive. I've had many people that have negative stool that have obvious refractory GERD that is H. pylori driven. You know, it's not just the gluten, it's not just dysbiosis. They have a continual drain of inflammation via H. pylori into the gut. And you can see that very clearly. I think I can't remember, it's either $10 or $25 to do an IgG titer for H. pylori. Very inexpensive. So, you know, I'm getting back to this four-dimensional program now, and I'm kind of ending on the eye. Hopefully it was enlightening. You've seen some things about the eye as, you know, it's really truly a window to your health. And it might be an aid as you're dealing with people that, you know, are stubborn about their periodontal treatment, that, hey, it's not just affecting, you know, your heart, it's affecting things that, you know, can really be important to you immediately, like vision. So let's talk about this and how we might be able to, I'm a slow learner. So why? I made the point earlier, 27 years, 30,000 doctors, one paper. You know, has anybody seen the PURE studies that were published 2 years ago? PURE, PURE studies. They were talking about carbohydrates and fats and anything, but, you know, you may not have read them. Okay, so my point about how impactful these population studies are, maybe not that great, but, you know, 180,000 people, 6 continents, 6 years. Really good data. We don't have to do randomized control trials to create evidence. But what we do have to do is amalgamate data into bigger data sets than we are today. And the only way we can do that is to work together, have some standard tests that we all do, aggregate it into EMR databases, data mine it, and publish that data. That's what I call a big, hairy, audacious goal. But, you know, my son's going into optometry, and I want to promote optometry as a way to really, as sort of a front line, just like I think dental should be for primary care for those who are disenchanted with the existing system, but we got to collect the data. The allopaths are all collecting that lipid and gaming information off of that. We've got to do the same, but with better information. So it starts way back, focal infection, dental origin. You know, Charles Mayo talked about the systemic oral connection back in 1916 at a keynote at a Chicago Dental. And, you know, he studied it for the rest of his life, and we haven't really gone that way in terms of promoting this as a major thing. You know, bone formation, tied to nutrition, 14 indigenous groups of people all over the world, same thing. Good nutrient density, good bone structure, healthy teeth, low levels of cavities. So the hint here is that if we have good determinants of health, good nutrition, good lifestyle, and good behavior, we're going to solve a lot of systemic health problems. And my point to you is you have people coming in motivated to change their oral cavity, but probably also motivated to change their whole milieu, but they may not know where to go. They may need help, and maybe you can guide them, shamelessly monetize it by giving them value, because they're not getting value out there right now. So, you know, I'm getting back to the oral and whole body health, and you know, this little slide just shows that The medical community admits, this is Kaiser, Peterson Kaiser, that ill-defined conditions are the most expensive when you really admit it. You know, doctors, you know, what is essential hypertension? It's elevated blood pressure of unknown cause. That's an ill-defined condition. You know, we can treat it with a blood pressure medication, but does that solve the problem? You know, I've been on a number of summits, and here's a very simple summit I was on, the Immune Defense Summit. And I got 631 people in 24 hours to take this little 16-question survey. And the people at Health Talks Online, they have 600,000 subscribers and 10,000 doctors. And I said to Bobby Cardwell, do you know who's coming to your site? You know, you're selling all these summits and videos and all that, but what do your people want? He goes, I don't know. I said, well, and by doing nothing other than posting a 16-question questionnaire, I know a heck of a lot more than you do about your people. I grade their risk score by grading question and answers, and I was shocked to see that health-conscious people got Fs. They had a lot of problems. You know, Ds, Cs, Bs, and very few had As. One of the biggest things is 58% are on meds, and 90% of those want to get off their meds. Or anybody promoting a program, come to me and I'll get you off your meds. We do, but you know, quietly do that. Then look at the diseases that they indicated, and maybe I didn't have oral up here high enough to promote it, but eye diseases were very high. You know, 48% said they were well normally, but lack of energy, sleeplessness, memory issues, eye issues. This is what I call the big O word. The big O word, opportunity. You know, what if you folks were doing this and then offering solutions to these myriad of other problems that are unmet needs by the people walking into your office every day? So these are healthy people, motivated people listening to these summits, just like the ilk of the people that are coming to your office. So I'll show you how we do it. We have a very simple online, white labelable 125 question questionnaire. It takes a half hour. It's based on functional medicine intake forms at Cleveland Clinic and others, except we digitize it, we can mine it, we can tell you what the complaints are, top complaints, bottom complaints, and we risk score everything, and then we create a very simple report. Still haven't learned, slow learner, MIT guy, what do you want? If anybody's interested in any of my publications, including sample reports, leave a card with me. I'll give you a private URL, but it's healthrevivalpartners.com/books. And this is one of the pieces of content out there. I have what I call my chronic disease assessment white paper. So I have a 40-page document that explains exactly why, who, what, why, and how I'm asking questions to measure those determinants of health. So it's just not pulled out of, you know, the sky. I explain exactly why we're asking the questions and what they lead to. And then we create a really good 4-page report. So if you can read your child's report card in an instant, you can quickly understand this by just, you know, they get a grade of a D. Here's some things, and we just highlight by color things that are low risk and things that are high risk, and we can sort the report. You know, I do ask dental questions. They may not be what you folks want, but, you know, I'm asking them some basic questions about oral hygiene, root canals, you know, implants, dental behaviors, things of that nature. And of course, we risk score each category so we can see where they're highest risk. And of course, we're asking about food, family, disease states they already have. Here's our blood labs. We have a panel of 55 biomarkers, 20 of which are really focused on chronic disease, which we've done deep dives into that mortality scale. And everything in nature is log linear. So like white blood cell counts at 5,800 or above start showing signs of early mortality. So how does it scale? It's a log linear relationship thereafter. So what we do for stickiness is we create a single number that amalgamates the 20 markers, and we call it your chronic disease temperature. It's based on 98.6. I couldn't decide ABC, 1 through 10. I could just see giving a 1 through 10 scale, and someone gets a 7, they say, well, everybody said I was a 5 in high school, so 7's actually an upgrade. I didn't want that. So we used the 98.6 scale because no one wants their child to be 98.7. So it's actually a scale of 0 to 7 bumped on 98.6. So this is 102.6, but then we look across disease categories and give a 0 to 10 scale of risk. We're not diagnosing anything. We're giving you a risk score. So we're staying safe within FDA rules, but then just sort of highlighting by color coding where you are for the various markers that drive the different diseases. And of course, they're all connected. So you see insulin repeating on almost every line, fasting insulin. Then what we've done, we're publishing this data, is we've built a correlation between how we rank and amalgamate all these 20 markers into a single score called the chronic disease temperature. And there's chronic disease temperature versus chronic disease assessment. So even though we give a letter grade, we actually have a digital number behind that letter grade. So now we can plot the lifestyle risk assessment versus the blood lab. So we're always trying to refine. We're not refining this because we feel it's objective, whereas this is subjective. So we're always looking at these relationships and trying to improve our risk algorithm. We patented this. We call it a health learning engine. And so, we're seeing, we want to get to the point where we can run a risk score and actually be able to predict the labs very well. So, of course, you can run the risk score for nothing. Okay, and then people say, well, they lie on risk scores. We've had amazing success with people that are motivated, to being honest. And, we do see a few that they don't quite jibe. But then we found out that a lot of people changed their lifestyle recently. And so their labs aren't catching up to the lifestyle changes. So we're measuring that as well. But we always threaten the folks, and we say, look, we're going to run labs anyway, and your blood doesn't lie, so you might as well be honest in the survey. And that seems to work adequately. Here's another thing that we offer kind of uniquely is someone will hire us to do an assessment of their brain through their eye. They go to our website, just download this grading sheet, and they go to an optometrist within our network, and they take our grading sheet with them. We don't ask the optometrist to make any assessment, but just to fill out standard grading levels for different things: cataract, different types of cataract, glaucoma, uveitis, measuring the retinal nerve, and then we give that a digitized grade as well. And of course, we'll talk to anybody who does the eye test and explain what it means from a long-term perspective. So, what I think particularly you biological dentists can do is meet a highly unmet need in a patient-centered way by working with the folks and gaining this kind of data on them, delighting them like they've never been delighted before. I can train any of you in here because we have a whole training program and PowerPoint on what each lab means and how to tie it together. Probably take an hour, because you folks already know labs pretty well. And you're explaining things to them in a way they've never been explained before. And if you don't want to do that, what we're doing with the eye doctors is you run your functional eye exam, a functional oral exam, and then we partner and work with these patients. And what we have is we have coaches of all ilks, from health coaches to nurses to NPs to other types of professionals that are doing active coaching with these folks on a daily basis, all through telehealth. So, here's something I've just transposed this from our ocular group, and it's a very simple thing. You hand this out in the office. You have a flyer explaining your functional oral program, like I had for the optometrist, but, why a functional oral assessment? How is a functional oral assessment different? What's the cost? What options do I have if my results indicate risks? And, you can either do it internally or partner with a group like me. Right now, I'm setting up with a couple of groups. It's taking a while, but I'm creating a Grand Rounds online telehealth portal. So it's no longer just one doctor or one health coach or whatever. The data gets fed in through our 4-dimensional assessment, and then we have a roundtable assessment of that patient with a robustly developed care plan that generally a coach can implement. I'll tell you a little story. So, is everybody familiar with what Hyman's doing with the functional medicine in Cleveland Clinic? Everybody have a grasp of that? Yeah. So here's an interesting thing that James Maskell, the head of the Functional Forum, just told me. It was in one of his Functional Forum podcasts. They're oversubscribed out 6 months, right? So, you're eager, you're motivated, you find out about a Cleveland Clinic and you want to go to the functional medicine thing and you're eager to get there, but your appointment's in 6 months. So what they do is they offer them an interim coaching program at fairly low cost to get you what I call pre-treated for the functional assessment. 80% of the people that had a functional assessment scheduled at Cleveland Clinic down the road cancel it because in the 6 months, the health coach solved that problem. So, that's kind of the power of coaching when you really recognize that food is medicine and everything you've heard over the talks today. But, the thing is, we like motivated people. We also like unmotivated people if we can, in populations, especially corporations, where we can get motivated people to motivate the unmotivated. But one-offs, I mean, there's a percentage of the people coming in your door today that have unmet needs. Tom Blue's the strategic VP of IFM, and I talk to him all the time. And matter of fact, I wrote him a nasty note during one of the talks today because I was trying to find a neurologist of a functional ilk in the Boston area, and I go to ifm.org and go to find the doctor locator, and you put in a zip code and a distance radius, and you get like 25 doctors, and then you have to laboriously drill down into each of their websites, if they have them, to find out what the heck they're doing. And of course, 15 minutes into it, you say, flip this. So I said, Tom, let's just create a simple patient-doctor matching algorithm. So someone can go in and put in some keywords and find a doctor. And zip code, what if I'm in Switzerland? I have clients in Switzerland. They're not going to come to Boston. You do telemedicine. It's like, it's archaic. So we've got to find systems to ease people, make it, lower the barrier to access good healthcare service. And guess what? You don't have to market it. They're coming in your door every day, I think. I mean, wouldn't you agree, Tom? They're coming in the door every day. Just to give you a little idea on our program, these are pictures. They're very static. But if anybody's interested, what Dr. Trump did. I wrote the book, The End of Alzheimer's, then Bredesen wrote the book, The End of Alzheimer's. And I give Dale all the credit in the world. His wife's functional. His book is a learning, easily implemented thing, whereas mine's a laborious, drudge through technical sort of manual on what the root causes of Alzheimer's are. And no one wants to read my book, and I get it, but I had to write it as my manifesto because Dr. Trump, and these are videos which I'd be glad to show you. They're on my website, my second website, which, the world thinks, things are siloed. So I have a website for eye and brain only, and then I have my Health Revival Partners, which is chronic disease. But in my Real Health Clinics, I have these two videos from 2006, and I can tell you this 84-year-old gentleman was a vegetable. He couldn't speak, he couldn't remember his daughter's name, he couldn't describe an orange, and then 6 months later, Dr. Trump made this guy, it was actually a bad thing, because he turned him into a typical crotchety Bostonian, who was very, very, very lucid. And it's hard to do this, and Dr. Trump didn't have a lot of these successes because, he's dealing with Mass General Neurology and a lot of naysayers, and who's this guy? He's an ophthalmologist, he's a quack. And, the thing is, when you have infection to that extent that your brain is degenerating, when you're treated, you're going to have a Herxheimer's reaction. Everybody knows what a Herxheimer's reaction, I assume, and it's going to be severe, even if you do the detox protocols and dose escalations and all that. So, you're already confused, your family is kind of tied into neurology, and you're making people worse. And I always tell people in my program, I don't care if they're 20 or 200, that if you're really sick and we're going to make you better, it's like this. You see a beautiful piece of land you want to buy, the plot of land, and you picture this beautiful, picket fence, white home on it, and the whole thing. But the intervening time, there's the roll-offs, there's the butt ends, there's the wood, there's, the porta potty. It's an ugly situation. And unfortunately, most of the time with end-stage disease that's very severe, that's what you have to go through as a process to get people out to the other side. That's why really the only way we can fix these types of diseases is to catch it as early on the continuum as we possibly can, because very few can endure this process. But I'll show you a couple people and a couple case studies. So you don't have to do heroic things. I tell my population, let's say we're going to have a financial transaction in 30 days, okay? And I can either have a check cut for you for $1 million, or today I can put 1 penny aside, give you the 1 penny. If I give you 1 penny today, will you be overwhelmed or underwhelmed, right? You'll be underwhelmed. Then tomorrow I put 2 pennies on the table, then 4, then 8, then 16. Well, in 30 days you have $10.7 million. In most cases you have a $5 million disease, so that $1 million check, the pill, ain't going to do much for you. So really it's the small things in life that add up, like a symphony. You hear the wind section, the string section, they're all discordant, then the conductor comes in and the baton goes across and everything sounds very harmonious. That's what really health is. So this person I'm about to show you went from 101.9, not super high, to 100.5 in 9 months. Went from a risk grade of C- to a B. You can see nice correlations, okay? And we were just dealing mainly in this area here, working on physiology. Still haven't learned. Here we go. This is an RA sufferer, which in his testimony, completely reversed. He went from could not make a fist and being a machine operator and having a hard time doing his job. And he was type 2 diabetic, and he said, 63 years old, he said at the end of the treatment, which was a 9-month process, he felt like 21. So who suffered from this process? His 63-year-old wife. That's a joke. Just saying. So, here's a lady with severe psoriasis, 4 dermatologists, all kinds of treatments, monoclonal antibodies, infrared radiation, no success, hadn't washed her hands in a year because of the pain, her heels were worse, and we didn't do much with her. I don't have the picture of that, but she was up in Indiana, and as they say, her diet was chicken wings and beer, and we just added a few vegetables and a little fish to it. And my favorite elixir. Anybody here ever hear of Weston A. Price? Having fun. You don't have to raise your hands that time. Just but the Weston A. Price Foundation, is it Sally Fallon and Mariana? They wrote the book, Eat Fat to Lose Fat. I have it bunny-eared. I think it's page 112 or something. And she says the ultimate superfood is cod liver oil, not fish oil. Fish oil is an A-, cod liver oil is an A+. Don't worry about rancidity. Get a good brand like Carlson's. But, I have a whole video on this. Back in 1848 in British hospitals treating consumption, tuberculosis is so bad that you're spitting blood. And if you're doing that today, antibiotics may not save you. By giving high-dose cod liver oil, 20 grams plus a day, up to 50 grams a day. So in my family, we do a half a shot glass of cod liver oil every night. It went from 6% survival to 18% survival. Now, in our world today, that's called a blockbuster drug. So there's a lot of people demonizing fish oils and worrying about rancidity. I'm a chemist, okay? Our olfactory sense for rancid fish oil is 1 part per billion. So when you're thinking it's rancid, very little rancidity. There's no connection between odor, olfactory, and toxicity. Think about carbon monoxide. You can't smell it, but it'll obviously kill you. So take your cod liver oil. The fish oils are extremely valuable for eye health. not Charles Sumner. Alfred Sumner has gone around the world under the Gates Foundation and given 2 cents of vitamin A to underprivileged kids in Asia to save their vision. Extremely important. Vitamin A is probably the strongest natural antibiotic we take. In cod liver oil, you get vitamin D of many of the isomers. It's not just D2, D3, it's D4, D5, myriad of isomers. And then it's the activated form that is the antibiotic. And matter of fact, calcitriol, 125-dihydroxy vitamin D, is actually a pharmaceutical drug used for end-stage kidney disease. What do you think is causing end-stage kidney disease? Well, it's either inflammation, sensitivities, or infection. So I can guarantee you it's probably infection, so that's what vitamin D is treating. And that's why I think it's helping you with sleep. It's downregulating inflammation, infection, and helping relax your cortisol response. So really, that's all I have for today. If anybody is interested in running our analytics, write to me. We can make it highly available. I think we have a tremendous opportunity to really provide service to patients that are coming to your offices, that when they leave the door and you're not offering services, they're lost. They're lost sheep. They have nowhere to go to. The functional doctors are too expensive. What I say is what I don't like about functional medicine is too much testing and too much reliance on supplements. The allopaths, too little testing. The testing they do is non-impactful and too much reliance on drugs. So everywhere in between, they're telling you that you cannot be healthy on your own. And we completely disagree. So I think our program is about 1/10 or less the cost of functional medicine over a year, and we're getting pretty good results. So, hey, I appreciate your time. I have no idea what time it is, but anybody have any questions? I'm going to throw you the mic. Oh, it's not in the ball. I can't do that.
If y'all can just come up here, that way I don't have to chase you down. That's perfectly fine. We have about 15 minutes.
Wow, we ran through that. My wife would say, don't give that guy a microphone. It'll never end, but we covered enough today. We'll get you.
Can you reverse Drusen?
Well, with the eye, it's all about mobility and chaperones, but absolutely. So Dr. Tremp, my mentor, really was working within the payer system. And when you look at these things, you've got to find the antecedents to drusen. So you do the testing, you do the blood labs, you look at homocysteine, you evaluate white blood cells like this, you may do some infectious. And he classically just used a cocktail of minocycline and clarithromycin because so many times that spirochetes are known to respond to that very well. And he was hit and run being a traditional doctor, see everybody every 3 or 6 months. But I believe if you use ozone or we're getting Herxheimer's reaction with biocidin. Next door, they're doing the biocidin biofilm busters. So I believe you can slowly. We've had cataracts slowly reverse. It just takes time. But more importantly, it's a screening tool to an underlying process. So if we can prevent that drusen, that early macular disease progressing to the next phase, but more importantly, bring your whole inflammatory burden down, then I think that's the most important result we've achieved.
Cool.
Does that adequately answer? Yeah. Yeah.
Anybody else? Come on. May
I ask a question without hanging up?
Go ahead. You'll get the mic, though.
Okay. My question is simple. Given the data, do you collect the data and use it for clinical study purposes, or do you ever share the data that you are gathering inside of the information you mentioned?
So, what we've done is we have a data set of about 500 people right now that we're mining, and we have just because I have bandwidth issues, if anybody goes on healthrevivalpartners.com/books, I have a little icon, population, and that has our pre-published, it's been peer-reviewed already, but I'm reconsidering the journal, that we're publishing that data. So, but in that process, we're developing sort of the analytical tools to really automate, because right now I'm hand crunching data. We have a HIPAA compliant instance where we're running our spreadsheets, but we're sort of hand manipulating that. And I'm actually working with a couple groups quoting for me AI analytics to mine that data. But you know, as our data set grows, we're just going to pick data sets and publish on it. You know, yep. But very willing to share the data that's all sanitized, because now it's just rows of labs, rows of risk portfolios, rows of eye assessments, and you know, tied to key, you know, an index number.
Anyone else? Going once? Going twice? Let's give him a hand, y'all.
All right, thanks very much.